Thank you very much. As we all know, there's a number of new health technologies and practices that have huge potential to improve people's lives. The key, though, is to ensure that the value that we are creating with these huge investments passes all the way down through the health system to reach the people who need it most. But there's a problem. As the value moves from the labs and manufacturing plants in the West to be distributed through the health systems in low-income countries, first in the larger cities and then to the remote areas, the challenges mount. The final segments of the value chain, down to the service delivery level, often called the last mile, are especially problematic. In effect, we're trying to reach these kids with a health system that looks a little bit like this truck. Today, I'd like to give you a quick overview of how we worked with the Mozambique Ministry of Health to improve the performance of Mozambique's health system at the last mile. So most public health systems in low-income countries are organized by state or province, then districts, then health centers. The distribution of health supplies follows this structure. So products move through a storage depot in the state or provincial level, shown as the intermediate store, then to the district level storage, and then on to the health centers. A collection-based approach is typical, meaning that each level goes to the level above to collect its supplies. But health workers are already overworked and overwhelmed. So when they have to find the time and transportation to get to their district or province to collect their supplies, this is a point at which the system breaks down. The result is the health centers are constantly out of supplies or stocked out. And if a mother has to carry her child for hours to come access treatment at a health center, only to be told that if there's no product, come back another time, her trust in the system starts to falter. So working with the Ministry of Health, we redesigned their distribution system, in this case for vaccines. We consolidated responsibility for the system, for the vaccine system, inventory management, equipment maintenance, and the information system itself to a small group of government workers called field coordinators. On a monthly basis, the field coordinators visit each health center to restock supplies, service equipment, and provide regular training. The health workers are then supported and have more time to do what they do best, provide health care. Now, everyone knows it's impossible to manage any service activity without information. With the new logistics system, the field coordinators carry information to the health centers, collect data at each health center, and then return to their office to input the data into an information management system. In northern Mozambique, most of the health centers are beyond the reach of the electrical grid, the internet, and even cellular networks. But the ongoing circulation of the field coordinators allows the Ministry of Health to move information from areas with internet-connected computers, 2G and 3G phones, and finally to and back from areas without any connectivity. So what we did was we designed an information management system that takes advantage of this circulation. Data comes from a number of sources: paper forms, SMS, smartphones, and computers. We're able to use the internet application to consolidate the data, then report it back as usable information to each of those devices. Health workers can use whatever device is available to them to report and access relevant information. Everyone then has the information they need to manage and improve the performance of the health system. So you'll note it's a little bit hard to see, but in the upper left is where a field coordinator would be inputting data. Here it's inputting data for the number of vaccines that were given at a particular health center. Since they're also collecting inventory data, it's hard to see, but in the upper right, it's telling them, what's the prevalence of stockouts in various health centers. You can take that information then and turn it into actionable information with dashboards, and this is for a manager overseeing the system, and he's got some work to do because he's got a lot of red that he's got to deal with. And then that information you can even go further with it. So for example, what you see there are the dots, little orange pins are the districts. The circles are the vaccinatable population of children in each district over a period of time. And since we know the products that are going out the door, we know the number to be vaccinated, we can create the coverage rate. What percentage is being vaccinated. And then we can map that against the government's targets. So if you're seeing a red circle, it's well below the government target, orange, yellow, getting better, green, you're on target. So it allows the managers to zero in and say, where are we succeeding and where are we failing? Next slide. We also believe there's a role for business to play in supporting the health system. In northern Mozambique, there was no reliable source of energy to support the refrigeration needed for the vaccine program. At the time, the best source of energy was propane, but it was only available 1,000 miles to the south. The Dutch Development Agency gave us a $1.5 million grant to build a propane distribution channel to support the health system. But rather than simply building the distribution channel solely for the government, with the donor's approval, we used the money to start a for-profit company called VillageReach. At first, 100% of VillageReach's customer base was health centers, represented below the white dotted line, really in this area right here. But over time, because there was broader demand for propane beyond the health system, VillageReach quickly began selling to restaurants, resorts, light industry, and households, adding that above the line section. With the expanding customer base has enabled the company to grow into a profitable and sustainable business. And now with a track record of operations and expanding market, we were then able to move to different sources of capital. Last year we completed a $1.4 million equity investment with a professional investment fund. They made the investment not only because VillageReach provided a social return by supporting the health system, but because they believed that there would be a financial return on their investment. Now, it's important to note that something very important happened here. So remember the $1.5 million grant that we used to start VillageReach and build the distribution channel? Well, that amount is still reflected in the valuation of the company. In other words, we built the missing infrastructure and provided support for the health system for over 5 years, and that $1.5 million is still there. So the final step in the transition will be to transition the company to traditional sources of market funding and local ownership. We're already seeing signs of that as a local private Mozambique company has shown serious interest in investing and eventually buying VillageReach. Any return will be reapplied to support the health system. So in the end, for us, it's all about measurable and documented results. So the new system substantially increased the percentage of children vaccinated to a number similar to what we have here in the US, over 90%. The system is also 20% cheaper for the government of Mozambique to operate. And with those documented results, the Minister of Health has adopted the system as government policy that will be sustained going forward. And also at his request, we're working with the Ministry of Health to scale the system to the entire country. Finally, VillageReach continues to grow and support the health system. Thank you.